Okay, now we're going to start the very first session of the day. Again, I'm afraid you're not getting rid of me. I'm standing up for this as well. I've got the joy of introducing two excellent speakers who personally I have learnt from and continue to learn from. Even yesterday we were discussing things that I was unaware of. There are three presentations within this section of optimising pharmacotherapy, and they're looking at different aspects of how we can enhance the patient's journey in treatment. So, without any further ado, I would like to introduce Professor Marc Auriacombe. Marc is a Professor of Psychiatry and Addiction Medicine at the University of Bordeaux. He's also an Adjunct Assistant Professor of Psychiatry at the University of Pennsylvania in America. Marc is also Principal Senior Investigator for an integrated addiction research programme funded by the French National and European funds. This is focusing on commonalities between substance and non-substance use disorders. Marc, thank you.
Thank you. Thank you, Duncan. Thank you for the organisers and for all the people and staff behind IOTOD for organising again this meeting and for giving me the opportunity to speak. I feel very privileged to be speaking and very anxious to be the first speaker. And the title of my presentation is New Horizons for Treatment, Translating the Latest in Research into Clinical Practice. My disclosures. The learning objectives, as they are on the program, is at the end, consider the clinical impact of recent developments in opioid use disorder, treatment options, and in a sense, what is it that is really new and that I can share? That's a big challenge for this presentation. So, because I'm very anxious, I need to get my anxiety down. And one way of getting my anxiety down is moving, doing exercise. This is very good to cool down. Thank you. But it's also an opportunity to show you my shoes. But let's be serious. So what is addiction? You all know the individual diagnostic criteria. At the far, on that side, you have the ICD-10 WHO criteria that have been around since the early 1990s. And on this side, you have the DSM-5 APA 2013, more recent diagnostic criteria. If you look overall, there are many similarities. One is that we need to keep in mind that addiction or use disorder is something that once it appears is long-lasting. That's why the diagnostic criteria are always kind of post hoc, in a posteriori manner. So this is a stable condition when it's there. Another thing is that the diagnostic criteria have very, very high statistical validity, and there hasn't been that much progress in over 20 years. One limitation of that is that it mixes both things that are core to addiction and things that are more peripheral. And today we have a better understanding of how the criteria might be in the future better organized. So we can look at addiction as something with a core and a surrounding constellation. The core is the concept that we all know of loss of control, of something that is a reinforcer, and it translates clinically by relapse, repeated relapse, and craving that was introduced in the DSM-5 as a new diagnostic criteria. But around this core, you have things that precede causes, of which we know very little, but pre-existing factors and risk factors around which we have lots of information, lots of data. And on the other side, you have consequences. Mainly consequences of the excessive use that is one of the outcomes of addiction, and related intoxication, withdrawal, and toxicological effect and impairment. This cleaning up, if I may say so, of the criteria allow us to better differentiate addiction as a mental disorder from use and its consequences, and will help target, clarify treatment targets, with craving possibly being something more important than we have thought in the past. Actually, one of the reasons for introducing craving as a new diagnostic criteria is not only because of its validity to tease apart people with addiction from people without addiction, but also because it has a prognostic value. Among people with addiction, it's a marker of how the disease changes over time. And this is new information that has been published recently. It has been shown that the relative value of craving at any given point, so how much is my craving now, higher or lower from before, predicts use. More craving predicts more probability of use, and this is both in a temporal monthly perspective, but also in an hourly perspective. But the reverse is true also. Reduced craving at any given point predicts reduced probability of use. So this really is a big argument to make craving, among other things, as a target for treatment. And this gives us the opportunity to simplify things in an area where it can become very complex, and it is in clinical practice very complex, and this will be demonstrated in further presentations this morning, later this morning, this afternoon, and tomorrow. So I'm trying to say that, everything could be explained by craving, but many of you have patients that will say, well, no, I don't have craving, my problem is anxiety, my problem is depression, and I have those patients too. And I would like to share with you some very, very new research that was from my lab by Melina Fatseas and Fuchsia Serre that has just been released on Medline. And they have been able to show that if it's true that craving predicts use and relapse, craving also produces symptoms of anxiety, depression, and thought distortion. But those symptoms, when you control for craving, they do not predict use or relapse. They're not associated to use or relapse. It's the craving that overrides the link. Now, what happens with patients that have co-occurring mood and anxiety disorders, which is something that, every clinical practitioner experiences? We have many of those patients. How does that change things? Well, of course, if someone has a mood or anxiety disorder, he has symptoms of anxiety and depression. But yet, when you control for craving, those symptoms do not predict use or relapse. However, and this has been replicated in some other studies, just having a mood and an anxiety disorder, individuals with mood and anxiety disorder have more craving. And having more craving, they have more use, and so they are more difficult to treat. However, the data show, and this makes sense also with the clinical practice, but it might be less frequent than we feel, that some of the excess use is not associated to excess craving. So the fact, but is not mediated by anxiety and depressive symptoms. So the fact of having a co-occurring psychiatric disorder is associated to some use that is not mediated by craving and could be explained by the long-standing hypothesis of self-medication of the actual psychiatric disorder. So, a question to share with you. In that perspective, what is the primary goal, what could be the primary goal, what should be the primary goal of medication for opioid use disorder? Number 1, press 1 for anxiety, press 2 for depression, press 3 for withdrawal, press 4 for intoxication, press 5 for craving. Vote now. And the vote, well, of course, maybe I kind of biased you. What would have been the answer before the presentation? But I think, and of course, we need to address all these goals. But there has been a big shift over the past 5 to 10 years compared to 20 or 30 years ago about the goal for medication or the goal for treatment in general in the addiction field and the opioid use disorder field, putting the primary goal on avoiding relapse through craving control and management of opioid withdrawal as a secondary goal. Now, what medications do we have for this, for these goals and craving included? And I'll focus on Europe. Well, and I'll go quickly on this because everyone knows this. Methadone has been, it's the it's the precursor of treatment in the addiction field, if I may say so, introduced in the very early 60s. Currently, 60% of treatments in Europe, mu-full agonist, NMDA antagonist, very effective, lots of data. Tricky to use because you can overdose patient if you don't control your prescription appropriately, your dosing. And the patient, if he doesn't follow doctor's orders, which normal patients do, is at risk of overdosing at the beginning of treatment, throughout treatment. The other medication that is more of a newcomer, although it's been around now for some time, late 90s, but in most European countries at the beginning of the years 2000, buprenorphine, either alone or combined with naltrexone, mu-partial agonist, kappa antagonist, very effective. I was going to say barely any side effects, very little side effect, very reduced risk of overdosing, but difficult to manage at the beginning, lots of dropouts at the beginning of treatment. That is a challenge for clinicians. And the remaining 2% is either those difficult to treat patients, treatment refractory patients, and the potential use of heroin-assisted treatment, and this will be addressed by another speaker further today, and slow-release morphine that is more country specific. All these medications, methadone and buprenorphine, there's also very good data now showing that the clinical target is determined by patient education on one side, but also by the dosing chosen by the prescriber. And low doses have an impact on analgesia, medium doses have an impact on withdrawal symptoms, but to have an impact on craving, you need higher doses, and you need to explicitly target that. Okay, so it looks, opioid addiction, in a sense, and that was written by some historical authors in the early 60s, should be a resolved and overcome problem. But it's still a problem today. So what are the current limitations? Although these medications are effective. But we need to keep in mind that efficiency is dependent on different factors. One is availability. And so I'm not sure, but up to recently, all these medications were not available in all European countries. And I'm not sure if they're all available. But I'm sure that they are not all available in the same regulatory environment. So in some areas, the availability is easier than in other environments. So that's a major element. Prescriber education, of course, is another important aspect, and that's what we're doing by sharing between clinicians and sharing our experiences between younger and less younger prescribers. And then you have patient collaboration. Patient collaboration is very important, but one of the limitations that we kind of forget is that there's a big burden for chronic treatments in general on patients, because they need to take the treatment every day or every other day. So they need every day to make a decision to organize themselves to take the medication. For us, it kind of looks as easy, but when you go from the patient's perspective, it's not that easy. It's not a problem for some patients, but it is for others. And compliance is not equal across patients, as you know. And as I mentioned, this is not specific to addiction, but to chronic diseases at large. Here you have a list, among many others, of some of the elements that contribute to lack of compliance of patients. One is misunderstanding of treatment goal and misinformation about addiction. And there is a lot of, quote-unquote, fake news about addiction and its treatment. You have both things, real fake news, and also that over the past 10, 15 years, our understanding as professionals has changed, and we need to educate our patients about this. Another element is about cognitive impairment. Our population patient specifically has cognitive impairments that might not help them to remember things they need to do every day. And inappropriate dosing, insufficient dosing demotivates patients and either has them misbehave, and that's not good because then we're concerned, and misuse, or drop out for treatment, which is not good either. So there's the potential advantage of long-acting formulations. In other chronic diseases, especially in psychiatric diseases, there are long-acting medications to help patients with compliance. And this is something that is coming in the field of addiction. To my knowledge, there are two buprenorphine long-act extended release buprenorphine formulations that are on the go in Europe. None of them, if I'm correct, are available in Europe. One is available in the US, but all are under investigation for being available on the market. So you have a CAM 2038 that is weekly. There's a weekly formulation and a monthly formulation. There's it's subcutaneous. They're all subcutaneous. You have a range of dosing that is interesting, but has its limitation: more range, more choice, more risk of not making the good choice. So that's a burden for the prescriber. There is studies showing, RCT study showing comparability to standard sublingual buprenorphine. And you have RB6000, also subcutaneous extended release, only available as a monthly compound. Limited range of dosing, interestingly, so less choice, so that can be an advantage or a disadvantage. An RCT showing that it's more effective compared to placebo, but I'm not aware currently of data available comparing to sublingual buprenorphine. This formulation is currently available in the US and under investigation in Europe. So to conclude, we are at this stage, although treatments in the opioid addiction field have been available since the early 60s, psychotherapy and social support has been available since always, but medications have been available since the early 60s. There's still a big potential for change in the treatment perspective. One is normalized like other disorders and other chronic disorders. No conditions for treatment access other than clarified diagnosis. We should not have prerequisites such as, does a patient want abstinence or use reduction, and what's the patient's motivations? These questions should come as secondary questions if treatment not work. A clarified objective for treatment also, which is to reduce relapse. And this can be either relapse rate or relapse intensity. Reducing the intensity of relapse without changing the frequency of relapse can be very, very useful and has a very, very positive impact on treatment. Having an explicit target to access this objective, and this is potentially craving. So we need to access craving, have the patients report craving, and then to try to monitor and reduce craving, and if medications are available, to make them in a patient user-friendly formulation, and long-acting formulation potentially could be useful for that. And abstinence and use reduction should be considered as consequences of treatment and not as prerequisites, which puts us, health professionals and prescribers, back into the center of the system and not as passive observers asking for patients to achieve what is our job. And this is more respectful and destigmatization for patients and helping people who are victims of chronic disorders. Thank you.
Thank you, Mark, for that fantastic presentation. We now have some opportunity for the audience to ask Professor Auriacombe some questions. If you'd like to raise your hand, there's a number of roving mics, and the staff will give you the mic to ask the question. And we can't see anybody from up here because the lights are too much in our eyes. Do you want me to start everything off and ask the first question? No, we've got one.
Hi, Graham Dixon, Agencia. I was really interested in the work around cravings and introducing that as a measurement tool for our patients. Currently, there's a very strong but reducing focus on abstinence and recovery. Do you think it's possible to introduce policy measures that say craving is the key factor, rather than just saying you're drug-free or you're not as the main outcome?
Yeah. So if I understood the question appropriately, it's should we, instead of targeting being abstinent or not, should we target having craving or not? Yeah, exactly. So, and at the policy level, right. And that's an excellent question. And that, I think, is based on the data available and that is accumulating since 6-7 years. This is something to consider, and it's the big challenge. So the implication being that a patient that is abstinent but with high craving is not a good outcome, and a patient that is still using but without craving is maybe just good quality remission. That's the challenge for the future.
Okay, thank you. Any other? Okay, I'll ask a quick question. What do you think the impact of the long-acting buprenorphine formulations will be on outcome?
Well, it's for patients that are compliant, none. You know, it's just an extra comfort. But for patients that are not compliant, and sometimes, you know, and are not compliant, quote unquote, not on purpose, then the patient just needs to make the decision once a week or once a month, okay, do I accept the treatment or not? And then he just needs to reassess that a week later or a month later. And I've been told, I think there are formulations that might be effective every 6 months. So then the patient needs to reassess his decision every 6 months. For appropriate patients, that can be very, very a big change, protecting them from, re-asking the question every day. So, I took it yesterday, I'll take it tomorrow. Why bother today?
Okay, thank you.
Cravings, the dose is very important, but psychosocial interventions and patient education are very important. Could you talk about decreased frequency of visit with longer acting agents?
Yeah, so excellent question. That's also the big challenge, because there's plenty of data showing that psychosocial support, from a quantitative perspective, impacts outcome, and potentially long-acting. And sometimes we have been kind of using medications on a daily basis to be sure to see the patient. And sometimes that I've read, some people have told me, well, you should underdose the patient a little to be sure he comes back, and you can do psychosocial support. When you think of it, if psychosocial support is useful, the patient should see that. I don't need to do negative incentives with other treatments. So I think we should combine things together and try to put we have to reduce the burden on the patient. It's a chronic disorder. The patient will need several years to manage that. And like for all other chronic disorders, we should target our psychosocial support to make the patient more autonomous.
You said all these medications are effective. To what extent they are effective, and what the criteria of efficacy? If you have some statistics or something, that's it.
So the question was, how much effective are these treatments?
Yes, how they are effective, and if you have some statistics about the efficacy, percentages or something.
Well, I'm sure many of the other speakers will be happy to say that. But overall, what I can say is, among patients that start treatments with methadone or buprenorphine, within a year's time, for those in treatment, you have over 80% that become abstinent and do much better in every area of life. So actually, the impact is very strong. Most of this impact is within the first months, which is a big problem for patients, because then they feel so well that they kind of forget they had a problem and drop out of treatment. So I think the efficiency of these treatments is so powerful that we don't see it sometimes.
That's the time up for the question.
I just realized that there's no translation this year, right? So, and just for the sake to everyone keep things in mind. So, some of you realize that I was speaking in English, not in French. I hope. However, I must say that when I used the word craving, I was speaking in French, and I don't know the word in English for craving. Thank you.
Okay, thank you, Marc, for that fantastic presentation.